Okay, today we're going to talk about the last section of pharmacology that we've got over. I've got both alpha and beta blockers on this slide set. I'm just going to do alpha blockers today. Collectively, these two drugs are known, classes of drugs are known as sympatholytics, where again, lysis or a lytic is something that breaks something, and they break the sympathetic stimulation to organs by virtue of the fact that they block the receptors that the sympathetic nervous system uses to activate those. So sympatholytics. And you can see here in our chart of all the drugs in autonomic pharmacology, and we're down to this group right here, and tomorrow we'll do that group right there. These are going to be shortish lectures. All right. So the best way to think about what happens with alpha blockers is to go back to think about what we just learned about what happens when you give alpha agonists. And some of the things that we saw and talked about, and some of this we didn't. But the predominant effects with blocking alpha-1 receptors were to stimulate alpha-1 receptors were to cause vasoconstriction. And you might remember that some of the drugs we talked about were used to treat hypotensive states, to raise blood pressure. That's what the agonists do. That you often find alpha agonists in nasal decongestants because they stop nasal secretions. We did not talk so much about their effects on the passage of urine, but if you think about what does the sympathetic nervous system do to the bladder, it inhibits emptying of the bladder, so an agonist should make it more difficult to urinate, and they do have effects on stimulating male ejaculation. I have not talked about the sympathetic nervous system or parasympathetic nervous system's activity and reproductive function, but just as a quick overview, both sides, sympathetic and parasympathetic, are involved in the reproductive act. It begins under parasympathetic control, that is in a safe, nurturing environment is where sexual stimulation can begin, and it often ends in a more emergency type oriented situation under the control of the sympathetic nervous system. There's some complex neuro processes going on there. We also talked about what happens when you stimulate alpha-2 receptors, right? And what we saw was an inhibition of sympathetic activity due to the presynaptic location of the alpha-2 receptors that would then, as you will recall, have an effect on calcium channels, to block the calcium channels, to limit norepinephrine release, right? And all that diminishes sympathetic activity. And then we saw pressor effects, or lowering blood pressure, because of alpha-2 receptor effects mediated in the cardiovascular control centers of the brain. So now we're talking about drugs that do the opposite of this stuff. Those were the agonists. We're going to talk about antagonists. And you should be able to anticipate to some extent what happens if you block the alpha receptors, what's going to happen to blood pressure, right? If you think about it, what you're going to see is vasodilation that's going to result in a decrease in blood pressure, right? And what's going to happen to heart rate? Well, you should be thinking that if you lower blood pressure, then you're going to get a reflex heart effect, and so what you're going to see is a reflex increase in heart rate, right? And so if we gave agonists to cause nasal decongestion, if you block the alpha receptors, you're going to see nasal congestion, stuffy nose, congestion, right? And in the bladder, where we saw that the sympathetic nervous system inhibited the emptying of the bladder, it does that by alpha-1 receptor effects. If you block those, then you're going to see urine flow. Urine flow, right? And I just mentioned this again because there's some involvement with the treatment of glaucoma. What happens in the eye, hint the dilator muscle of the iris. What does that do under sympathetic stimulation? What happens to the size of the pupil under sympathetic stimulation? The dilator muscle contracts, and that's an alpha receptor mediated effect. If you block that, you're going to see a small pupil, which we know by the term miosis. Okay, so these are collectively some of the effects that you could expect to see if you block alpha 1 type receptors. We'll talk about alpha 2 just a little bit. So the first drug in this is an old drug. It's rarely used anymore. It's got a specialty use. The name of the drug is phenoxybenzamine. It's a long-acting drug, and the reason that it's long-acting is that it is a non-competitive antagonist. It makes a covalent bond on the alpha receptor, and that effectively destroys the alpha receptor. It has more of an effect on alpha 1s, a higher affinity for alpha 1 receptors than it does alpha 2 receptors. This drug is reserved for the treatment of severe cases of a condition called pheochromocytoma. Pheochromocytoma. And this is an adrenal tumor that secretes a lot of norepinephrine. Adrenal tumor at a cancer on the adrenal gland that results in greatly increased levels of norepinephrine and epinephrine. Right? And attendant with this condition is a radically increased, a severely life-threatening increase in blood pressure. And since that blood pressure is largely mediated by massive vasoconstriction that's mediated by alpha receptors, it does the patient good to knock off their alpha receptors and reduce the tone of the sympathetic nervous system on the blood vessels. And so it acts as a vasodilator to lower blood pressure. There are some predictable effects. You start knocking off the alpha receptors, you are significantly going to lower blood pressure. You're going to see reflex tachycardia mediated through the baroreceptor effects. You're going to see nasal decongestion because you block those alpha receptors. In males, you'll see an effect on ejaculation through alpha 1 receptors. We're going to talk about the specifics of that, and I mention it again before I get to the graph that shows it. You're going to see orthostatic hypotension. And just as a reminder, orthostatic hypotension is the condition where your body quickly responds in an appropriate fashion to maintain blood pressure when you go from lying down to standing up. And if your body does not respond that way, then you're going to feel faint and may pass out, have that feeling of, oh, I stood up too fast. And the reason why is that your body uses alpha 1 receptors to cause vasoconstriction to keep all your blood from falling down to your ankles. And alpha 1 receptors mediate that effect. And if you block the alpha 1 receptors, you're going to see the orthostatic or change in posture hypotension. You'll also see meiosis, inappropriate urine flow perhaps, and effects on blood pressure because of the vasodilation. You'll see decreases in both systemic and diastolic blood pressures, which means that there is a lot of vasodilation going on. So that's the first drug, phenoxybenzamine. You probably never see it in practice, nor this one either. This is an older drug that has the same effect, with the exception of the fact that this is a competitive antagonist. It just lasts, its effects are seen along with the half-life of the drug. It is active at both alpha 1 and alpha 2 receptors, and there's a consequence to that I hope you'll understand by the time this slide is over. It can also be used in the treatment of pheochromocytoma, maybe in conditions that are not as severe, so severe that they call for the use of the previous drug, phenoxybenzamine, but still could be used in pheochromocytoma. And the adverse effects are similar in that they cause a reflex cardiac stimulation, a reflex tachycardia. I put 2 pluses there because this is more tachycardia than you might expect, mediated through the baroreceptors. And the reason you get more than expected reflex tachycardia is because this drug also causes, because of its vasodilation, will cause an increase in sympathetic tone that is not controlled at all by the presynaptic alpha 2 receptors, right? Remember that alpha 2 receptors are presynaptic, so here's the sympathetic neuron, right? And it's releasing norepinephrine, and it's got alpha 2 receptors over here presynaptically that the norepinephrine will feed back on to limit how much norepinephrine comes out of the cell. Well, those are blocked by this drug, so you don't get that negative feedback. So the amount of norepinephrine that's released is larger than there would be if you had active alpha 2 receptors, which again you don't because the drug's blocking them. So that means that the reflex tachycardia is greater than normally seen with just regular old alpha 1 receptor blockade. And not surprisingly, we see, and that's a perennial test question to make sure that y'all understand this much complexity into the pharmacology of this drug. You'll also see unexpectedly nasal decongestion. It may cause a headache due to the vasodilation. Some headaches are mediated by excessive vasodilation. Again, an effect on male reproductive function and a decrease in ejaculation. Orthostatic hypotension, not surprising. Meiosis, just as we saw before. And again, incontinence or excessive urine flow. All right, so that's phentolamine. That's the second drug. And then here's a series of drugs that are specific for alpha 1 receptors. They're not purely specific, but they're considered to be highly specific. And these drugs begin with prazosin, whose brand name was Minipress, but it's off patent. It has a bunch of brand names now. Desoxysin, which was Cardura, and terazosin, which was Hytrin. And all of these three drugs were used to lower blood pressure. They're not first choice drugs anymore. At one time in our past, they were considered good drugs for lowering blood pressure, but not so much anymore. And then the fourth drug, I typed in a different color just to distinguish it from the others. This drug, tamsulosin, whose brand name is Flomax, but there is generic available now. And this drug is used to increase urine flow deliberately, increase urine flow. I should change the color of my pen, but I didn't think about doing it. Increase urine flow. And this is a condition for the treatment of benign prostatic hyperplasia, which I'll show you a picture of in just a minute when I get around to talking about the ejaculatory function as well. So tamsulosin or Flomax, and the Flomax gives it away what it's for. So in terms of their receptor activity, which I call their pharmacodynamics, you see much greater specificity at alpha 1 than at alpha 2, and they are competitive antagonists, and they are predominantly used as vasoconstrictors with the exception of tamsulosin. In their clinical use, again, lower blood pressure, but they're not a first choice drug anymore. They also may be used, however, in the treatment of a thing called Raynaud's disease. And Dr. Panis has this, and he may have talked about it in class. And what it is a condition where you have excessive sympathetic vascular tone on the extremities. And that means that there's a reduced blood flow to like the hands and the feet, and it causes the hands and feet to be cold all the time, and it can be painful because if you restrict blood flow to an area, it causes pain. And it's what causes Raynaud's disease, we don't know, but individuals have excessively cold and if they're white, very pale hands and feet. And that's Raynaud's disease, and it's because there's too much sympathetic activity on the vessels, the blood vessels in the extremities, and that sympathetic activity mediates vasoconstriction through alpha 1 receptors. So if you block the alpha 1 receptors, it relieves the symptoms of Raynaud's disease. They're also used in the treatment, as I said just a moment ago, in the treatment of benign prostatic hyperplasia, and they provide symptomatic relief. They don't actually treat the disease, they just treat the symptoms, which the symptom of benign prostatic hyperplasia is the difficulty urinating. It's very common in older men. And if you block the alpha receptors, what you get is an increase in urine flow that's actually beneficial to patients with this disease. And again, tamsulosin is the alpha 1 receptor blocker that's used for the treatment of this. Their adverse effects are similar to what we've seen before. a tendency towards orthostatic hypotension because the blood vessels can't constrict when they need to, a reflex tachycardia, but not as much as phentolamine because these drugs tend to leave the alpha 2 receptors alone, so you have that negative feedback mechanism on norepinephrine release that remains intact. You may also see some nasal decongestion and again some headache due to vasodilation. Again, the effect on male reproductive function, again, meiosis and incontinence due to the fact that there is an alpha 1 receptor on the sphincter of the urinary bladder that keeps the bladder full. You block that, bladder empties. All right, and so here's a picture that demonstrates this. And this figure is focuses on the condition of benign prostatic hyperplasia. So here we see, I'm going to circle it right here. This is the normal prostate gland right here. And as men age, just as their noses get bigger, their ears get bigger, right? Lots of things get bigger. The prostate gland gets bigger. And so what we see is the prostate gland becomes much larger, right? And as it enlarges, here's the pathway. Let me go back to the left side. Here's the pathway for urine to flow, right, down out of the bladder, and the sphincter muscle is right there, and urine flows through the prostate gland and out, down the urethra and out of the body here. So as the prostate gland enlarges, it starts to impinge on the sphincter muscle of the bladder right here to prevent it from opening as efficiently as it would when the prostate gland was smaller. And so the idea is that if you use an alpha receptor blocker, then that facilitates the opening of the sphincter muscle so that urine will have an easier time of getting out. Now, the thing that I kept talking about with ejaculation is that it's not shown here, but if the testes are here, then the seminal and ejaculate material comes up from the testes through the vas deferens, around, and eventually through the prostate gland as well, and out through the urethra, sharing a common pathway. Well, especially as the prostate gland enlarges, what happens is that the ejaculated material has some resistance in its path, normally going this way, but under the influence of an alpha blocker, the pathway up towards the bladder provides the least resistance, and so the ejaculate will go into the prostate gland and then back up into the bladder. And this is, excuse me, this is effect is known as retrograde ejaculation. Retrograde ejaculation. And so you'll see that in the literature going forward as your career advances. You'll see a wide variety of drugs, especially some of the drugs that are used for central nervous system disorders, also cause retrograde ejaculation. And they will expect that someone has explained this to you, and now I have done that. So that's the alpha 1 receptors. So that wasn't too bad a list of drugs. Looking at alpha 2 receptor antagonists, I don't know of any FDA drug that's used as an approved alpha 2 antagonist. There is a drug that you can buy, through various vendors. You could probably buy it at Walmart as an over-the-counter drug. It's controversial. The drug's name is yohimbine. It's derived from the bark of a particular yohimbine tree, and it's been known for a long time, correctly or incorrectly, as effective to treat male sexual dysfunction. We call it an erectogenic, and that it helps generate penile erection in men, which facilitates the actual sex act. It also is thought to stimulate libido, which is the mental side of the sexual drive rather than the physical side. The libido means the desire to engage in sexual activity. that for legitimate sources will caution against the use of this compound, because when you consider the actions of alpha 2 agonists that we looked at previously that lowered blood pressure, etc., and caused a certain amount of calmness and sedation, this is a drug that will block those effects. So I just say consider what the actions of alpha 2 agonists are, and then think about what happens if you do the opposite of that. And it should be obvious that there's some cardiovascular risk. I read recently a meta-analysis. A meta-analysis is a study of a collection of previous studies, right? So you find all these previous studies, you put them all together, and you collectively analyze all of their data at one time and say, okay, so what's the net effect after I read all these papers and analyzed all their data? What do I get? That's a meta-analysis. And the meta-analysis said that it was cautiously optimistic for the use of yohimbine in ED, which is known as the abbreviation for erectile dysfunction. But the study goes on to say, given the problems of quality assurance and quality control with nutraceuticals, meaning they're not FDA regulated, we really don't know how much active compound is in the pill, or how it was made, or how pure it is. The overall consensus was that this is not something to be recommended. All right, so this gets me into the beta blockers, and I'll just do this slide because it's so fast and then quit. But for beta 2 antagonists, there's only one compound that I know of that's a beta 2 antagonist. It's called butoxamine, and I don't know that it has any clinical value whatsoever. So that's a thought to leave you with until tomorrow. Hope you're doing well.